Going to go ahead and begin. So tonight is kind of a mixed bag of objectives, and I'll cover the objectives when we get to the next screen. But first of all, thank you guys for being here. Greatly appreciate you popping on so we can discuss dementia care advocacy, the guide program, and an upcoming meeting and so forth that's going to be coming on. I put this picture on here. It's my oldest daughter who just started OT school. Jada is the little baby. And that's all of her grandparents and great grandparents. So, and a couple had dementia diagnoses as well. But older adults has always been my thing and my passion and so forth. So I had that picture on there for another thing I did. So I popped that out today. Most of you on here, I know, so this will be redundant for you, but there are a couple of people that are new that I have not had the privilege of meeting. So thank you for joining us. My name is Kara Welke. I'm an occupational therapist, graduated back in 2000 with my master's degree. I did go back in 2017 and got my OTD when I was teaching. Long story about that. But anyways, I own Home Therapy Solutions, and we are a mobile outpatient private practice. And I like to say that we are the best in our area in providing dementia care for clients with dementia and their caregivers. Obviously, I'm biased, but that's one of the big areas that we focus on and do a lot with. We do utilize the Skills to Care program a lot. We do cognitive stimulation groups and offer a variety of other group programming in our areas. So that's kind of where a lot of my passion stems for. I started the business in 2018, and we have several more staff than that. We need an updated group photo. And then my other passion area is helping therapists start and build their own business. So we have several therapists who are joining us tonight that also have practices just like myself that provide therapy for dementia care or for clients with dementia and caregivers. So two reasons why this area is very passionate for me, because it impacts my personal business and the people that we provide services to in our communities. It also impacts all the therapists that we have helped over the years who have started and built their practices, with many of them working with clients with dementia and their caregivers. So objective wise, the objectives are for you guys to be knowledgeable about the guide program. And you might, again, I'm not an expert in this, but I can show you the information I know and where to find more information and help guide you a little bit. But hopefully you'll have the resources you need to do some further research. And I look forward to hearing from those of you that probably know more than I do on this program. I also want you guys to be aware of how this model may impact those who already provide services for those with dementia and their caregivers. I would like, we do have some people that have joined us tonight that are looking at starting and building their business and providing these type of services to their clients. So by some of the things I share and some of the other therapists on here will share, hopefully you will gain a glimpse on what you can do to provide services to those with dementia and their caregivers. Additional objectives for tonight is we want to gain valuable feedback from those attending in order to learn more about what others are doing across the United States. And thank you to AOTA for helping us getting recognized with CMS as being, a very important component of dementia care. But also, if it wasn't for AOTA, I wouldn't be having a meeting with like 9 people from CMS who actually are key components of this program coming up. So thank you. Scott's on here representing AOTA tonight. So thank you to AOTA for doing that. Because it's huge. And those of us in private practice, we are the ones on the ground doing the services every day, seeing what we're getting reimbursed, providing these services, and we have to be willing to step out and approach AOTA, approach these committees or organizations, so that we can continue to advocate for each other. So, if you're not an AOTA member, I'm telling you, you really need to be, because it's the backbone of our profession. And with AOTA, we wouldn't be represented and be part of this model if it wasn't for AOTA. So I'm not going to go into all of that, but I'm just consider it, please, because we need to be representative. When I was at the conference, I think like 20% of OT's professionals are AOTA members. And we need to have more people at the table in the government sector, as we know. So I need your feedback, and that I can help take to this meeting that's coming up. And many of you know Rachel Wiley. It's way past her time when she's usually in bed. So, and she's had a long couple days. She in fact trained one of my therapists this past weekend in skills to care. So I will be meeting with her as well, and hopefully she can attend the meeting as well with that. So that's kind of where we're at, and hopefully what you'll gain tonight. And I am going to minimize this real quick so that I'm going to be going back and forth between slides. So hopefully that won't mess you guys up so much here. Sorry, moving between two screens. Okay, so with the guide model, well, first of all, I'm a huge proponent of outpatient private practices. Obviously, probably one, because that's the type of practice I have, and that's the type of practice we help therapists start. Just out of curiosity, how many of you have an outpatient hybrid therapy practice that are attending tonight? Just put I do or yes if you guys do have that, just out of curiosity. But I personally feel that an outpatient hybrid practice is the absolute perfect place for occupational therapy practitioners to be, for so many reasons. But it's also a great place for physical therapy professionals, SLPs, and so forth. And what I have found is there are so many people that have no idea what an outpatient hybrid therapy practice is. I recently attended the American Geriatric Society conference, and I don't think there was anyone there that had any clue what an outpatient hybrid practice was. They're very familiar with home health and hospice and outpatient care. But when we are going to be talking about the guide model coming up, you're going to specifically see that as part of the beneficiary and eligibility and alignment, it's our exact clientele. The guide model is designed for community dwelling Medicare beneficiaries, including Medicare beneficiaries who are dually eligible for Medicare and Medicaid. And the eligibility criteria for the guide model are beneficiaries that have a dementia diagnosis are enrolled in Medicare Parts A and B. They're not residing in a long-term nursing home, and they're not enrolled in Medicare or in hospice, and they're not enrolled in PACE. So again, we are, obviously, again, I'm biased, Scott. Sorry, you have to hear this for the 10th million time from me. But I feel we are the ideal people to be providing care for older adults with dementia and caregivers. And when I first saw this guide model, I'm like, well, that's what we do already. We do everything within this guide model, right? But just to show you, we do align with the eligibility requirements already in many of the different areas. Another thing I want to point out is our practice and many practices that we work with in our Therapy Business Builder program are age-friendly therapy practices. If you're not familiar with age-friendly healthcare, Google it, you'll see it. It's a big push across the United States and beyond, worldwide, for healthcare practices working with older adults to become an age-friendly practice. Not to brag, but my therapy practice was the first one ever to become an age-friendly therapy practice. And then, I think Megan, she's on here, she's in North Dakota, was the second one to become. And then we have others throughout the US that have become age-friendly therapy practices. But the thing is an age-friendly therapy practice, I can probably guess that most all of you that have a practice are doing everything that is the requirement for this practice. We have to do what matters. Again, as OTs, we do the occupational profile with all of our clients. We focus on what matters and so forth. And I know PTs and SLPs do as well. We have to look at medication. And there's a whole spiel on that. We have to look at mentation, and we have to look at mobility. So another huge proponent, and this fits well into the guide model, as you see when I come on to a couple of the other screens here. Now we're going to come back to this in just a second. I want to show you this resource. So this slide is available. These slides are available to absolutely all of you. I'll put them in the chat. So obviously I'm not going to go through this slide word by word, but I want to kind of go through some of it with you for those of you that aren't familiar with what this guide model is. And then we'll come back to my presentation and talk about what we're doing, my feedback, and then we're going to open it up to hear from the rest of you guys. So, so this was a presentation that they did. Oh gosh, I think it might have been back in August. So this is what they did in August, and you can listen to the recording as well. Some of the cool things, all of these people except for Emily, I think, are attending the meeting that is coming up. So again, that's why it's so important that I hear from you and gather as much information from you guys as well when we meet with them. So the purpose, the model purpose and overview, it's to improve quality of life for people with dementia and their caregivers while delaying avoidable long-term nursing home care and enabling more people to remain in their home. How many people have a business that is already focused on these goals right here? Improving quality of life of people with dementia and their caregivers, delaying avoidable long-term nursing home care, and enabling more people to remain in their home. Okay, so I'm guessing I'm speaking to the choir tonight, which is awesome. So with this model, they are looking at care coordination and management, caregiver support and education, and respite services. So out of curiosity, for those of you that have these, 3 goals for your practice, how many of you feel like you're already providing care coordination and management, caregiver support and education, and respite services. If you could list, if you're doing all three, great. If you're just doing two, what two are you doing? If you're just doing one, what ones are you doing? So if you could provide some feedback on that, I'd love to hear from you guys where you're at. For my practice, I feel we're doing all three of these things. And I'll talk to you about, as we move through the slides tonight, how we are doing all three of these things. So, okay. And that's what I guess. I'm guessing that the respite care is probably the biggest piece that is missing from a lot of people's businesses. We collaborate with services that provide the respite care, and I'll talk a little bit about that as well. So that's the model, purpose, and overview. As far as who is eligible to participate in the guide, I'll go over this in more detail in my slide, but they kind of have it broken down into a single Medicare provider with multiple suppliers. Several Medicare providers and multiple suppliers can form a dementia care program. Then there's Medicare enrolled provider establishes a new Part B, enrolled 10 to form a guide dementia care program. Now, the thing is that our type of mobile hybrid practice actually isn't able to provide this. We have to connect with someone else, which is one thing that I have questions on. So throughout this slide, they talk about different things, and I'm only gonna kind of chime in on some of the key things. So this is what I was talking about earlier when we talked about the beneficiary eligibility and alignment, who it's for. And again, this is for the majority of us who provide mobile hybrid outpatient practice. They are looking at have different tiers, and based on, the mild, moderate, severe dementia, and they're looking at beneficiaries with a caregiver and those without a caregiver. They have established a care delivery approach that includes a standardized care delivery, an interdisciplinary care team, and standardized training. Now, another question I have for you guys, how many of you guys feel that you already provide a standardized care delivery program for your clients with dementia and caregivers and utilize an interdisciplinary care team? Who else uses more than just OT or just speech or? Okay, good. So Joanne, hey Joanne, thank you for popping on tonight. I appreciate that. So Joanne works with the state of Idaho, or they're working with the state of Idaho to develop and provide standardized training. Good. Anyone else? I mean, we utilize an interdisciplinary care team, and I'll show you that in a moment here. So they have some requirements for the interdisciplinary care team. They talk about having a care navigator, and they have in quotations here, dementia proficient clinician. So the interdisciplinary care team will assess the beneficiary and their caregiver across a number of required domains, including cognitive function, functional status, clinical needs, behavior and psychosocial needs, caregiver burden, with the goal of confirming a dementia diagnosis and creating a comprehensive care plan. So, how many of you guys feel that you are already assessing all of these different areas that are going to be a requirement of this program? Any areas that you don't feel like you're assessing? So chime it below. Cindy, but why? Why does it need to be an MD or a DO? One thing to question. So Melissa, yes, sounds like skilled to care. Care delivery requirements. So they're looking at that we have to have a comprehensive assessment, we have to have care plan, 24/7 access, ongoing monitoring and support, referral and support coordination, caregiver support, medication management, care coordination, and transition. So when I look at these requirements, and obviously I am a hardcore OT at heart, and think we can do all of this. But I feel all of this is very OT driven. I don't know anybody's thoughts on any of these different areas or things that you think are not within our realm. We'll talk more about that, Dana, as we get going. So they have on here, they have an example of a beneficiary and the situation and the process that it goes through. And I would like you guys to just sit down and look through some of these, like this example, and see what, I just love your feedback after you go through that. I want to talk a little bit about the payment methodology for this. And I'm just gonna skip on down to this here. So what they're looking at is a monthly payment rate for people that are enrolled in this program. So the highest level would be $360 a month for the first 6 months, and $220 a month after the first 6 months for beneficiaries with a caregiver. Monthly payments for beneficiaries without a caregiver are a little higher. And then of course we get into the payment adjustments and so forth that are beyond my level of explanation right now. And then they also talk about the reporting. So with this model, and if you are going to be in this model, there's going to be data that they need to collect, right? So the guide will require participants to report the following. They're going to have to report quality data, care delivery data, beneficiary and caregiver assessment data, socio-demographic and health-related social needs data. So a lot of data, right? And think about that on top of what services we're providing, as well as what the payment is looking at. This is more info on expanded data collection efforts, and so forth. So they have a model timeline of when this is going to be rolled out. They have a variety of resources that you guys can check out, and so forth. So that gives you a little bit, hopefully a background about the guide model. Now I'm going to talk to you more about what we currently do at my practice and why this guide model concerns me, and to get your guys' feedback. So, okay. So in that per beneficiary per month payment, the services that are being included in that payment, like the $360 per month, is care management and coordination, caregiver education, support services to beneficiaries and caregivers. Now, the respite care payment is separate, and I think it's $2,500 or is it $2,600? If someone has the exact amount, you can put it in the comment section there. So those are separate. Now, yeah, thanks, Scott, 25. So, Amy, we have we still don't have absolute clarification on if we can bill regular therapy sessions if they are part of this plan. We can bill regular therapy sessions if they don't have to do with dementia. But we're not sure with all the other services we're already doing. So that's more info that we're working on collecting with that. And Scott might have more to say in the chat section on that, and we can bring him on as well too. So the other thing I wanted to point out is I firmly believe as an outpatient hybrid practice, we already have a billing TIN, we're a Medicare Part B provider. Why can't we be the ones that apply for this program and do this program? And the answer sounds like it's because of the different assessments. They're assessments that Medicare or that physicians include. Scott, if you could put in the CPT codes that the physicians can bill that include those assessments. But I still am a proponent on that we should be able to do this. So just to give you a little idea of our practice, the Home Therapy Solutions here, we work very closely with several geriatric nurse practitioners and physicians. We do have one particular geriatric nurse practitioner that we work very closely with. And then, of course, we have OT. We work very closely with non-medical home care companies to provide respite care. And we have a great program in our state that if anyone has a caregiver, they can basically qualify for this respite care program where they get about 8 hours a week of respite care. And it doesn't matter if they make $0 or $1 million, they can qualify for this program. So we specifically have worked with people in our community, OT students, PT nursing med students, other people that are interested in providing respite care, and some of them have actually become certified dementia practitioners, and they're able to provide respite care. And through this program, again, they can get like 8 hours a week, or they could use more, at a time. It's like every 3 months they get so many hours with that. And some of the non-medical home care companies can provide this respite care, but when one of our clients uses a non-medical home care company for respite, they get less hours than if they would use an individual. So we've been working on trying to get as many individuals to become respite care providers that are also trained in dementia. And then we work with them and educate them on providing care to the client and the family. And then our physical therapy is, of course, very involved with our clients with dementia and caregivers as well. And then I think, Joanne, was it you who mentioned this, that, the Alzheimer's disease has a wonderful 24-hour helpline that we utilize, because that's another area that is a requirement that some people are concerned about. So yeah. Try to think if there's anything else on that. So yeah, we work closely with all of these people in our community. We also work with the Alzheimer's Association and other community organizations in order to provide the best care possible. For North Dakota, it's a respite program specifically to dementia. We're able, I believe they're supposed to have some sort of cognitive impairment, but they're pretty good about if a caregiver needs assistance to help us get that program set up for them. So why I feel us as occupational therapists are very perfect for this type of model and this type of practice. And I know PT and SLPs, you guys can do this too. This is just what I know. So one of the things that we have to do as part of the guide program, or that needs to be done, is like a person-centered care plan. Well, with us as occupational therapists, we're going to do the occupational profile. We utilize the Skills to Care program. I personally love the camp. is a great caregiver assessment. We do a home assessment. We utilize the BCAT and the PHQ-9. And I don't know if you guys are familiar with the Home RX. It's a medication assessment tool. If you're a member of AOTA and go on to AJOT, you'll be able to find information on that. If you want the specific tool, you can let me know. I've made connections with the person who developed it. But there's some good research behind to support that. And again, with being an age-friendly therapy practice, we have to cover the medication realm as well. Care coordination. So in our practice, we actually do a ton of care coordination. Because we are in the home providing the care, we're the best at being able to coordinate that care. So we help set up and coordinate services with the family, and it's worked very well. Caregiver services. Our role with that is we assess and assist with setting up caregiver services, and we do education and training for caregivers. And a lot, some of this stuff can be ongoing depending on what kind of caregiving services they're utilizing. If a caregiver changes and they need re-education, training, things like that. Additional services that we provide, we have a community connections program that we offer 2 times a month. This is a program where our clients come in and have social interactions, because we all know that social interaction is extremely important for all of us, but especially this population. And while the clients with dementia are there, then we have a caregiver support group as well. We also do cognitive stimulation therapy groups, and then we are starting some computerized cognitive treatment that we provide as well, that has a lot of great research behind it. So these are the different areas that are a requirement for the care plan. So just to give you an overview of what, what I feel, how we cover this program as occupational therapists. We use the home assessment and the other assessments as appropriate to assess the client. We use the CAMP for the caregiver. And then we collaborate with the nurse practitioner for her medical assessment. For the care plan, we collaborate with the NP, the client and caregiver, in order to establish the care plan. The 24/7 access, we utilize the Alzheimer's 24/7 line. For ongoing monitoring and support, yep. Can you not see my screen, you guys? I hope it's sharing. Is Ezzy the only one not? Okay. Phew, panic attack there. For the ongoing monitoring and support, we do maintenance therapy. I don't know if any of you guys attended the Center for Medicare Advocacy webinar they did recently. It was the 10-year of the GMO settlement. I'd highly recommend checking that out and looking into maintenance therapy and what we can do and utilize. But we do a lot more ongoing monitoring and support than most people are getting on a regular basis. Referral and support coordination, that would be our occupational therapist. I should have occupational therapy professional on that, because if we had an OTA in that role, they could do that. Caregiver support, again, we do a ton of training and education with the caregivers that are providing support. We also hold different events and connect them with other resources. With medication management, we do the home RX, and we do a lot of medication reconciliation, both working with the nurse practitioner and with pharmacists. And then care coordination transition, again, the OT and the nurse practitioner work very closely with care coordination and transitions. We do this in the home, but we also work in memory care facilities, assisted living facilities as well. So this is to give you a little idea of what we bring in from one client, so you can see how it would compare to the guide payment of like $360 a month. And you got to use your imagination, because I'm pretending that we see this client like the first or second day of the month and seeing them all month. And obviously that's not the exact scenario. So you just got to be a little flexible here. So as far as when we first see a client, the occupational therapist will go in and do the initial assessment, and, say that's 1 hour in the home. With the Medicare and the supplemental reimbursement, we can average about $150 for that. Next session, maybe that session is the one where we do the home safety assessment as the focus. The following session, maybe we initiate the skills to care and do the camp, the caregiver assessment at that session. The next session, we might continue on with the camp. There's other assessments and so forth that need to be done with the skills to care. That might be that session. Then the other sessions could be anywhere from doing anything with skills to care, care coordination, other treatment, caregiver education, training, and so forth. So it's likely that we could see a client, 2 to 3 times a week initially, and provide skilled therapy services. So just saying that we saw a client for 1 evaluation and 7 visits, this would be about $990 for that month that we would bring in. Now, with a nurse practitioner, they're also, cost money, right? So this is just kind of an average if they did an initial assessment, and then if they do a follow-up assessment in the month. Now, with our nurse practitioners, and yours, all of them are different, they might do 1 initial assessment and follow up the following month, or they might even see them 2 or 3 times. I swear we've had some clients lately that they've seen them multiple times in 1 month. So looking at those 2 visits, $225. So month 1, as a business, how we stand right now, would be $1,215 versus with the payment rate of either $360 or $390 per month. That's a pretty considerable difference. And for those of you that have practices like this, what I'll be asking of you as we move forward is, giving us scenarios of how it is where you're practicing as well. As we continue with a client, it really varies on the client and the caregiver and what they need. This is an example of only doing OT once a week, but there might be some clients that we continue to see twice a week for a few more weeks, or maybe longer duration, depending on the severity and what we need. I was just going to tell you about an initial evaluation one of my therapists did the other day that should have been divided into like 10 different sessions. But anyways, you probably have all had those, right? Nurse practitioner, if they do a follow-up assessment, maybe like $75 for a 30-minute follow-up session. So month 2, $555. Again, compare that to that $360, $390 range. Now, again, we do maintenance therapy, and this would be an example if we decrease down to every other week, where, that would be $240. And then if they did a follow-up appointment with a nurse practitioner, $75. So that comes to like $555 for the following months. So that's how our program is, and how we provide services, and how it compares, because I wanted you guys to see an example of what we do, and then think about the guide model and the services they're asking, and think about the payment that they're going to be reimbursing us. And now I want to hear from you guys. And I'd love if you guys want to, if anyone's willing to come on and talk about the services you provide and give examples. If you want to just ask questions, open it up for discussion. But what I'd like to do is, yeah, just open it up, because we want to hear from you guys on, is this similar to what you do in your area? Do you provide less? Do you provide more? What are your thoughts? And if anyone is willing to come on and just speak, let me know, and I'll pull you up into a discussion. So Cindy, the fees are so low, the local medical memory care practices are not interested in joining the program. Okay, very good to hear. Other feedback or questions that you guys have? Where did they get the fee schedule? No idea. Scott, if he's still on, may be able to, yeah, and may be able to answer that question, Deborah. And Scott, like Scott said, it's important to note that payments will be channeled through the primary provider, not paid directly to an OT service provider, because we can't be the ones, the way it's set up now, to provide this. So through the guide model, the payment comes into the primary provider and then they send that out. Yeah, that'd be awesome. Just 1 second. There you are.
Hi, guys. Oh, you can actually see my little picture.
Yep.
So I just want to clarify a couple things. So I think it's really important that people understand, again, the payment methodology, as Kara alluded to, we're not completely clear how they came to those numbers, but that they looked at, oh, who am I? I'm Scott Trudeau. I am the director of practice engagement at AOTA. I am an occupational therapist who's been in practice for about 42 years. Over the course of my career, the bulk of my career was in developing models for dementia care and researching those and working with interprofessional teams across the trajectory of dementia illness to define models, initially working on developing some end-of-life models for hospice and then outpatient and community interventions, and did a fair bit of research in the area of home safety for folks with dementia. So that's my background. I've been at AOTA for the last 8 years. And when this opportunity came up to talk to CMS about dementia care, I was chomping at the bit to do that. So the payment methodology is not completely clear to us. And really the key point for all of us on this call is that CMS has not disclosed yet what codes are included in this bundled payment and what codes will we continue to be able to bill for. So it is not impossible. I'm not saying it's highly likely, but it's not impossible that some of the reimbursement that Kara just described will continue to be billable services within the model or over and above the model. Now, again, I can't guarantee that. I don't know exactly. And we're supposed to know when the request for applications is posted by CMS. It's supposed to be a lot clearer what will and won't be paid for under the bundled payment. So hopefully that will be released. So we've heard in November is the target. for when that request for applications will be released. So we'll know better about how to set up this practice model once we see that. Right now, what it looks like is that folks who are interested will need to basically contract with a primary provider, whether that's a nurse practitioner, a physician practice, or a PA practice. That person is going to be the point person, because these reimbursement structures were developed off of those evaluation and management codes, which are only billable by the primary provider. So that's what I know so far. But hopefully Kara might get some new insights when she meets with CMS next week about some of these details. Happy to answer any other questions. I haven't been able to watch.
I think there's a few, Scott, that would, some people are asking, what about the cost for the person to gather and report the data and the costs associated with running the program? And there are some grant opportunities for new programs, right?
Yeah,
Scott?
I know that, right. I know that there is startup costs that would be a one-time lump payment for practices who are interested in developing the full package of comprehensive care. And again, exactly what the details are of that, I'm not sure, but they have suggested that there would be startup costs that would be provided for folks who are interested. The initial rollout is targeted for next July, but that July of 2024 will be people who are already doing these kinds of comprehensive programs. Anyone else is targeted to start July of 2025. But there would be that year of prep and startup, basically, year between 2024 and 2025 to get all your ducks in a row. One of the things that I mentioned to Kara, so those models, the three models that Kara showed us on the CMS slides, are just proposed options that CMS came up with in terms of how they could envision these practices being set up. I do think that there may be other creative ways that you all might think in your own communities to partner with providers in order to set some of these things up. And one of the things in particular that I've talked to a couple of folks about, I think I mentioned this to Kara, is that if you're already doing a lot of these services, but don't have that Medicare TIN provider, then maybe you would be in a position to look for startup costs to recruit and hire a nurse practitioner to come under your umbrella and work for you, as opposed to the other way around. So instead of the money being funneled through another practice, folks who have embedded practices but just need that provider could potentially hire that provider to change the model, to change the paradigm. So I think it's really important to see these as examples, but not as the only recipes for how folks might meet the standards of the program.
Scott, this is a really good question. Amy asked, and I'll give my feedback on this too. So Amy said, I basically do this already, so wonder why I'd venture into this since the payment is lower than billing my time via CPT codes, no financial incentive if I can basically do this already. From my perspective is, this is a federal program being pushed out that they're looking at, trying to be a standard in dementia care and so forth. And the services we provide us as OTs really need to be advocating our services and what we provide, that we do provide the high standard of care. So it is tough because I'm like, I should be part of this program if it's supposed to be this higher level of care for people with dementia, so that kind of bothers me a little. Scott, do you have anything to add to that?
I really don't disagree at all. And somebody asked about whether or not CMS has any idea of what our scope of practice is. And the fact that, again, if you're looking at the screen, who's eligible to participate, the words occupational therapist are in the center of the screen on that slide. That's really, really, really critical. And it's a result of the advocacy. They came to us and said, do OTs work in dementia care? And we jumped at the opportunity to show them the evidence, to show them the practice models that have been developed by occupational therapy to meet the needs of the dementia population. And they bought it pretty much hook, line, and sinker, if you will, right? They understood that our holistic background and our perspective is invaluable to the care of folks with dementia. The problem for me, right, is less about whether or not we belong here and more about whether or not we can afford to be, and that's what Amy's question is, right? Can I afford to be part of this program? And I really think that, unfortunately, I don't want to keep sort of begging off of responding by saying this, but we really have to see what the codes that are going to be included in the model and excluded from additional billing, what codes are there? And is it possible that we would continue to be viable with some of the codes that we're already using for these hybrid outpatient programs, that we could continue to bill for and be part of the guide program? That to me is the best outcome of this, because as Kara suggests, if occupational therapists don't define ourselves as part of this federal program now, I don't know how many of you were around when the hospice benefit became a CMS benefit, but if we don't define ourselves now as part of this model, we may be excluded later on from, however dementia care is going to be paid for in the future. And that's a little bit of what happened with us with the hospice program. The hospice benefit suggests that we are important as an ancillary service, but we are not a core component of the hospice benefit. And that has shot us, somebody said, selling ourselves short. And that's exactly what we're concerned about. Now, that being said, I'm not unrealistic, and I don't think people should jump off the bridge just because they say this is the model and this is the direction. If you can't make a viable business decision to do this, then that's a problem. And we'll keep advocating, and we have advocated, and we will continue to advocate with CMS that we can't afford to be part of this program the way it's funded right now.
And Amy, I'd say if you can provide a case study or an example showing, your business and where you're at and what you would bring in, that would be great support that we can share with them. Because like when I met with AOTA, they're like, and I showed them my example. I mean, that's great, but we want examples from across the United States, right? To hear from other people. And another person has talked about primary care providers, geriatricians not having the time to do this. And that is so true. When I was at the American Geriatric Society, a conference, they don't have time to see patients as it is, let alone trying to do a program like this. Okay, I'm trying to see what other questions I am seeing. How does a patient get signed up for this program? I don't know that, do we know this, Scott?
So they voluntarily have to sign on. So if I'm working with Dr. Smith and I have dementia, Dr. Smith decides he's gonna be part of the guide program. They come to me, they say to me and my caregiver that the guide program is an option. This is what it will provide. This is, what we're offering. Are you interested in participating? I say yes, I sign on. I go into the program and I work it for a couple of weeks, or a couple of months, whatever. My wife, who's my caregiver, says that she doesn't like the program anymore, and we voluntarily step out. So it's a voluntary, the beneficiary and the caregiver are the ones who decide whether or not they're going to participate in the program. Now, that being said, there are parameters, as we talked about, in terms of who's eligible. So they have to be a Medicare beneficiary, and they have to go through the process of being diagnosed and tiered in terms of their eligibility.
And Melissa, I agree. I mean, we can't afford to take a pay cut to participate in it. So that's why we're advocating. That's why, I mean, again, I think on social media, we all know negative Nelly spreads like fire, right? About this or that. I mean, we have to support our organizations like AOTA. We wouldn't be at the table. We wouldn't have our name front and center on page 8, 9 here if it wasn't for AOTA. So we need to be members of AOTA. We need to reach out to AOTA. I mean, I wouldn't have a meeting with the people who are working on this model if it weren't for reaching out to AOTA and AOTA setting it up. So all of us here, if you can just do whatever you can to advocate, help us with figuring, providing us with information, send emails to them. We're going to try to figure out what we can all do to advocate there. So let's see. Yeah, I'm just going through.
I had a question about APTA. I'm not aware that APTA has been directly involved with advocating one way or the other. So that's all I can say, is I just don't know. But certainly the again, the more holistic quality of life kinds of interventions that are embedded in dementia care are much more consistent with the occupational therapy scope of practice than with the physical therapy scope.
Awesome. So what I would like from you guys, if you are willing and already providing services like we do, if you would be able to just share about your practice, provide us with a scenario, that would be awesome. We will send out a form following this meeting to collect additional information from you guys that you would like us to take into account when we meet with CMS, any additional questions you have. I'd also, recommend that you guys reach out and email your comments and feedback to the guide model team as well. And any suggestions you guys have that we can all work together and advocate for our profession, what we do, and get clarification on some of these questions will be important. So one thing that I was going to add that's a concern for me with these type of models is some businesses might consider signing up for programs like this and providing the bare minimum of services. And so then the clients then don't get as much as they realistically could from some other services. So that's always a concern that I have. Also, some OTs have mentioned that, they have a concern that because of the data requirement, bigger healthcare systems might be more apt to do this again, but minimize what kind of services are actually being provided. So some other concerns that we have heard. So again, if you guys, couple things to think about, really consider becoming an AOTA member. With all the things going on, we need more of us to be AOTA members. Two, please provide feedback to myself on, your business, what you guys do. We'll probably have a smaller joint meeting for people that are interested in having more of a game plan going into our meeting. Also, email CMS, ask Scott questions as well. Again, Scott, thank you so much. I know it's like after 10 o'clock your time for coming in and presenting to us. And oh, awesome. Thank you, Mary. She's been an AOTA member for 37 years. Awesome. I'm guessing the majority of people on here are probably AOTA members anyway. So, but if you could help spread the word to other practitioners out there about all of this, it would be very helpful as well. We'd appreciate it. I'll stay on for a little bit longer just in case anyone else has specific questions or thoughts for me. Otherwise, I especially know those of you on the East Coast, it is late and probably past bedtime.
10:05. Good night,
Well,
folks. Thank
you,
you.
Scott. I
Feel
really
free-
appreciate you jumping
Feel
on.
free to reach out if you have further questions. Take care.
Thanks.
Bye-bye.
Bye-bye. Michelle, I don't know if you're still on. Holloway, you asked what is your rate to pay respite workers? So our respite workers in the state of North Dakota, they're called qualified service providers. So yes, Joanne, reach out and we'll set up a time to meet for sure. But our respite workers are qualified service providers with the state of North Dakota. So they actually are like independent contractors with the state of North Dakota, and they get almost $22 an hour, which is pretty dang good. I mean, obviously you got to consider that they're a 1099 and taxes doesn't come off with that. But gosh, I don't know if Megan, you're still on or not, but it might even be more than 22 now. They've had some pay raises. They've even both of my daughters are qualified service providers. One's in nursing school and one's in OT school, and it's a perfect fit for them going through school. And yeah, I mean, they get paid well for doing that. Awesome. Thank you, everyone. If you have any other questions, let me know. Okay, you guys all have well, one more question. Okay, you guys all have a fabulous night. Hey, Deborah, I'm gonna miss you on my trip to Vegas. Taking Chuck and Long instead. I need a bag. You know what, Deb, you should market your little bags for travelers. I need to put one of those together. Okay, everyone, have a good night. We'll talk to you for long.